My name, again, is Ben Kremer. I'm the suicide prevention coordinator for one of them for Eastern Colorado. And we're going to kind of talk about suicide as a whole problem, and I'm going to touch on a lot of different statistics. So, of course, I don't think anyone doubts that it's an issue for veterans and our general population, but sometimes it's pretty important to kind of know some of these details to just help really conceptualize what we're all dealing with before I'll hand it off to my coworkers here. So, without further ado, I'm going to give you a snapshot of risk. So, suicide is the 10th leading cause of death in the United States, and coincidentally, it's also the 10th leading cause of death in Colorado. And also, every stat I'm going to share is tragic in its own right, but as you can kind of see, it's also the second leading cause of death in the world for 15 to 24-year-olds. So it clearly is a problem that is starting earlier and earlier that has to be addressed. So a few ways of looking at that is that, nearly 1 million people make an attempt every year, and that can kind of be broken down into 1 in 35 seconds, totaling more than 45,000 U.S. deaths from suicide each year. Breaking that down, right, in the time that we're talking, right, every 12.3 minutes, someone actually dies by suicide. The more we can learn about the who, what, where, when, and how, the more targeted interventions we can kind of create from a population perspective and, of course, from individual perspectives. So one example of that kind of identifying feature is that we do know that there's at least one gender disparity, which is women attempt suicide 3 times more often than men. And then on the flip side, men actually die by suicide 4 times more often than women. So clearly, there's always going to be different groups that we might potentially have different interventions or different strategies because, people are individual and people attempt suicide for individual reasons, but we also can use big picture data to really help understand what's going on. So data keeps coming in. It's usually a few years behind because it's hard to collect this type of data from the multiple sources. But you can see here in the top, right, that the rate of suicide was 2.2 times higher among female veterans compared to their non-veteran adult women. So what that tells us is that that's a pretty big difference, right, between women, veterans, and non-veterans. And then when you switch over to the males, it's actually only 1.3 times higher among male veterans. So that tells us that males are more similar kind of regardless of their veteran status, which either way points to knowing that, suicide prevention policies and strategies need to be applicable to everybody, of course, besides veterans. 2 groups that are kind of highlighted note are the males 18 to 34, as we were just touching upon with the Afghanistan situation, the last 20 years of combat experience. This group has the highest rate of suicide. So they are definitely, right, they get discharged, and we have to really get our hands on them as quickly as possible to make sure that they get the support that they need. The first year and first 3 years are a higher rate or a higher risk period for veterans transitioning because of readjustment and any other sort of common sense idea you could think about just going from one type of environment to a new environment. And then the other block that's really a concern are the 55 and older males, because that group is just so large that there's just more of them than everybody else. And of course, more population, more everything, the numbers tend to increase by that alone. So bottom line is about 69% of all veteran deaths result from firearm injury. So this slide is relatively new in terms of data, so I was able to get this. So the main takeaway is here that sometimes we, divide the United States into, sections, and so obviously Colorado is in the western section, as you can see for the blue. The two main highlights this slide kind of represents is that suicide rates in Colorado are significantly higher than the national suicide rate. So it means that we have our work cut out for us here, especially because it's just higher. The numbers are higher for us. And of course, if it's higher compared to the national veteran suicide rate, it's also significantly higher than the national general suicide rate. So you can just see here that for 2018, there was about 173 total suicide deaths for veterans. And then I thought I would kind of connect that dot with kind of the United States. So you can obviously see the different color codings, and it kind of goes from white to blue to dark. You can see that the western half is darker and bluer than the eastern half. Of course, who knows exactly why that is. And fortunately, Colorado is not as bad as it could be, as you see Wyoming and some of those other darker blue states. But the bottom line is it's a problem everywhere, and it's especially a problem here on the west side of the United States. So, of course, right, as we're going to talk about, like what the VA has to offer and, what do we do about this, it's kind of good to know, right, because the VA is the healthcare system for veterans, but veterans can, of course, get care outside of the VA. So you can kind of see here that roughly 50% of veterans do not use their VA benefits or the healthcare system. And then on the right side, you kind of see that veterans who use at least one VA benefit or healthcare service are the other half, but only about 30% of that half use all of the available resources. So the goal is, you can see at the bottom, there's not enough space for every veteran to come to the VA or all the VAs. The bigger point is that we need the communities, no matter if it's VA care or community care or whatever type of care, we just need to make sure they're getting the care that they need. You might have heard different numbers around what has been the number of veteran suicides per death or deaths per day. The true number at the moment is 17 deaths a day. And you can see here that 11 out of 17 veterans, they're not enrolled in our healthcare system. So that's why suicide prevention has kind of its internal parts about what we can do for the veterans who we actually have our hands on. And then we have a whole nother section about how do we support those other 11 veterans who we don't have our hands on. So this is pulled from actually the Colorado website, that's a Colorado State website. You can basically track up till 2018 the suicide death rates per counties. So this you can kind of see that the bluer counties are 9 out of 10 of them are in the Front Range, with Mesa County on the left being that other 1 out of 10 county that has the highest count. And you can see El Paso County is very dark. El Paso County, of course, has a lot of veterans, a lot of active duty members, and El Paso County has its own county task force. It needs extra attention, and we all know it needs extra attention, so we're definitely working on that. The two main points of this is that, of course, where more people live, that's where more deaths are going to occur, but we also can't forget about all of the rural areas, because rural areas, they can be harder to access care. There can be different cultures that maybe influence whether people seek care, so we can't forget about the rural veterans as well. So we kind of identified 6 different reasons that we think play a role in what creates our Colorado suicide risk. So one, we've identified that there is a higher gun ownership rate here, and as those couple slides ago were alluding to, is that most or 69% of firearms or suicides are caused by firearms. Firearms are obviously very deadly, and so guns equal more successful suicides. It's just the way it is, and so that's why a big piece of suicide prevention is, of course, engaging the lethal means safety component of gun safety, making sure people know about it and can have the potential protections they need if they so want to. Number 2, I just touched on, right, barriers to care in rural areas is always going to be a challenge. Hopefully the expansion of telehealth and telemedicine can support that. Higher rates of substance use, and those can, of course, then affect mental health outcomes. Obviously, an easy thing to note, too, is that we're one of the few, couple states that have legalized marijuana, so there's just even more access to, legalized forms of drugs or alcohol. Obviously, Colorado itself has a higher concentration of the veteran population and active duty, and people often, when they retire, still choose to live here because hopefully we all like Colorado. Number 5 is population increase, which, as I've touched on, more people generally equal higher numbers, no matter what statistic you're talking about. And from that Colorado website 1 or 2 ago, that website also tracks industry. So you can see here that actually if construction jobs and the construction injury has the highest industry rate of suicide. So you can probably take a guess that there's potentially, more males, more young males working in that field, on-off work schedules, you name it. But we do have more and more data even about industry-related statistics. Healthcare is actually, I think, number 2 or 3 on that list. And then this is a relatively new area of research, but Colorado with its high elevation, we know that elevation is we've identified that elevation might play a role in how effective medications are metabolized. And if it's not metabolizing correctly, it's not working to its full effect, and therefore it's not playing the role that it could be. So, of course, the key here is, that no one issue, organization, or person or intervention can prevent suicide. It's multifaceted, right? So you can kind of see here from the bottom that, individual and population health, up to your social relationships, individual risk factors, where you live, do you have a job, family, right? Like any factor of life you can think about can kind of either be viewed as either a protective factor or a risk factor. So really, when you think about helping a veteran or helping any fellow community member, if you're helping them, you are, in a sense, playing a role in suicide prevention, even if you don't think of it from that perspective. We certainly do here at the VA. So the way we kind of say that is that, suicide prevention is everyone's business. Clearly, you all believe that, or you wouldn't be here today. Whether it's mental health or any other issue that people need support with, it really is everyone's business. It's our families, it's our friends, it's our communities. You go into any group of people, chances are, someone could raise their hand that they're a veteran, and that's important to keep in mind. So part of the kind of pillars, we need to connect and reach with the veterans and their families, build community engagement, of course, change the conversation around suicide, There is and still a stigma around suicide, around talking about mental health and suicide, asking for help. So every time you have an open and honest conversation about suicide, you're helping change the culture in this country around making it more acceptable. Of course, whatever potential innovative strategies we will continue to create, and there's an Office of Mental Health and Suicide Prevention, which is always working on disseminating best practices, informing policymakers, that type of thing. So every year there's usually a campaign from the National Suicide Prevention Office. Last year was Be There, and this year it is Reach Out. It has dual meanings, meaning one, if you are a veteran, please reach out for help. And of course, if you aren't the veteran and you know a veteran, you should reach out to them and check in on them. So you can go to reach.gov, /SPM if you want to check out that. And then, I will transition it over.
Yeah, I think I'm a little too short for that placement. All right. So I don't know if you guys can actually see me standing behind this.
Scoot over a little bit.
Well, I might just
There you go.
go ahead and... Does this work?
Yeah.
This is... Sure, that'd be great. Oh, the fun of being short. My name is Dr. Musicaro. I am, as they said, the clinical psychologist and the local recovery coordinator. So I want to talk a little bit about the services that we do offer across Eastern Colorado healthcare system to support the veterans. So as you can see on this image, there is a continuum of services that we look to offer at Eastern Colorado as well as across any VA, hopefully, nationwide. All of these services should be based off of recovery-oriented principles. If you look at this graphic, you might notice a couple of things. So the bottom talks about self-directed care. When we think of self-directed care, I think about the things that people often do before they ever reach out to the VA, right? So that might look like anything from peer support, not such as Crystal, but reaching out to their battle buddies and people that they served with, right? It could be talking to their trusted friends and family and supports, assuming they have ones that they feel comfortable speaking with. It could be looking at some of the resources that are online. So the VA has veterantraining.va.gov, which has some veteran-facing skills on there. So there's a parent training, there's one called Moving Forward, which is a problem-solving therapy. There's one targeting anger management. So it might be looking at some of those different resources. It could be utilizing the phone apps, whether they're the VA phone apps or utilizing some of the non-VA phone apps. But either way, usually before anyone ever tries to come into the VA, they try to figure out whether or not they can white knuckle it on their own. And so whatever resources they utilize, that's the self-directed care aspect, right? The main way that they come into our system is called primary care mental health integration. Has anybody heard of this term before? PCMHI. All right. So fun fact, every veteran that receives health care from the VA is assigned to a PAC team, which is a patient care alignment team. Patient alignment care team? Primary care providers, nursing staff, all of those fun supports. But attached to every one of those primary care teams is a clinical provider, whether it's a PCMHI does have psychiatrists in Colorado, luckily, but they're typically social workers, LMHCs, LPCs, or psychologists. And they're integrated in to where the idea is if primary care or nursing assess that veteran and recognize that they might be having some difficulties, whether it is with mild to moderate anxiety or depression or health-related worries, anxieties, they tend to pass that veteran off through what we call a warm handoff to their primary care mental health integration team. So that clinical social worker or therapist will usually meet with the veteran a couple of times and see whether or not it's just needing a little of support or extra skill building. And if they recognize that that veteran's going to need a higher level of care, then they move on to mental health. They can refer up to that. And that is where I would say the majority of our veterans tend to house, right? So general mental health, we see everything from non-combat related PTSD, so childhood, relational abuse, those sorts of things, bipolar disorder, schizophrenia, schizoaffective disorder, anything in between. So in general mental health, and I'll talk a little bit more about that in just a minute, so I'll keep going. As we move up this continuum, it becomes more and more specialized, right? So as you move up to the continuum, it's going to be a higher and higher level of care. So there's going to be a greater emphasis and demand on what we are going to want to support that veteran in order to meet their unique recovery goals. That being said, if you notice on the side of that pyramid there's still self-directed care. So the elements of recovery say that recovery is not something we can do for you. Recovery is not a target. It is not a goal. It is not if you come in and you do what I tell you to do, because I am the doctor and I clearly know best, then you'll be okay. It doesn't work that way, right? So at the end of the day, there's always going to be two experts in the room. The VA provider might be the expert in what is relevant as far as diagnoses, treatment options, so on and so forth, but the veteran's always going to be the expert on themselves. And so in order for us to really support the veteran, we want to encourage them not just to utilize the services that we have to support them in their recovery journey, but to continue to utilize the services outside of the VA, right? Continue to utilize those phone apps, continue to utilize the online resources, the peer support, which is a wonderful resource, and Chris will be talking about peer support in the VA in just a moment, but there's a lot of peer support opportunities in the community too. So there's an organization called Warrior Now, and it's built off of the basis of peer support. They have daily buddy check-ins every day at 7 p.m. through digital meetings. Continue to utilize that if and as needed, right? NAMI, the National Alliance on Mental Illness, has a wonderful variety of different peer-led and peer-to-peer programs. So we want them to continue to utilize the services within the VA, but also start to build that network of support outside of the VA, right? Build that continuum so they have that wraparound care and they have the resources, not just during the hours that we're here, but whenever they might need it, even long after they stop coming into treatment and after we've reached their goals. So let's talk about goals. I say the word recovery a lot, all right? When people hear the word recovery in the context of mental health, the first thing they tend to think about is substance use. That is not what I'm talking about. while it is important, it is certainly an element. When I talk about recovery as far as mental health, I'm looking more at the idea that when people get a diagnosis, they tend, as those symptoms increase, that becomes the focus. If we don't watch out, that doesn't just become the focus, that can become their identity, right? So recovery to me really is about having a foundation of hope. Hope that there is life after the diagnosis. Hope that you can get to a point that you can use those resources, whether it is in the VA's continuum of care, or if it is more along the lines of that self-directed care and everything in between, to where you can figure out what works for you. What's that combination of supports, of skills, of people, to where you can find that balance, you can regain that control, you can start to get a sense of who you are, not without all symptoms, because recovery doesn't mean an absence of symptoms. It's not a cure, right? So our goal is not to say that you will recover when you no longer have any symptoms of depression, you no longer have any symptoms of post-traumatic stress disorder. No, instead, recovery is trying to find that balance to where, in spite of having symptoms from time to time creep up, you're going to know how to approach them, how to manage them, how to understand them, how to accept them. And you can put them on the back burner and continue to live your life, whatever that might look like. So it needs to be built on hope. And
I'm sorry.
And peer support.
I accidentally touched it.
It's okay. One of the other things to keep in mind is that recovery should be respectful, right? Respectful of the fact that there are two experts. Veterans and any person, regardless of what system you're getting your health care in, you should be given information. And you should be able to give information. Everyone is unique. We have different values. We have different goals. And our goals are not always going to be the same goals as our healthcare providers. If I see a treatment plan that says the veteran stated goal is to maintain my medication, I go to that provider and I say, no, it's not. Because that's the treatment person's goal, right? That's the psychiatrist's goal. The veteran's goal might be, I want to stay on my medication so I can save my marriage, so I can maintain employment, right? It might be more along the lines of I want to manage my anger, but why? What's important to that? So we need to be able to recognize that everybody is going to be different. They're going to have unique experiences, unique cultures, unique backgrounds, unique pasts related to trauma. And all of that is going to come together to inform what is important to them. If we are not figuring out what is important to them, you want to reduce your symptoms, but why? Then we're not going to get them there. People rarely do what they tell themselves that they should do, but they always find a way to do what they want to do. So we need to find a way to link back. Why is recovery important to them? Why is it worth pushing through and learning the skills and utilizing them, even on days when we're still not feeling our best? What's the payoff? Anything you'd like to add?
I just want to definitely add, recovery is definitely nonlinear. And I really like what Dr. Musicaro, what she said about that. Recovery does not mean, the absence of all symptoms. It just means when I speak to, my fellow veterans about it, I'm like, okay, I still have trouble from time to time. But the difference is, instead of it taking me completely out and completely down to a point where I'm again suicidal or can't get out of bed or can't relate to my family, things like that, it's much less. I can identify the warning signs earlier. I can say, okay, here we are. Not judge myself, remove that self-internalized stigma and say, okay, this is a thing, we're gonna address it, here's how I can work on it, and I'll give myself some time, and it just helps you kind of get back on track. So recovery, again, it's having those tools, having the plans in place, having the support, the open communication with your family, and just being able to kind of like bounce back easier.
You want to switch spots?
Oh, sure.
One thing I will add from behind the computer is if you look at this this slide, you might notice that every element has two different roles, right? The role of the VA provider, the role of the VA staff, or honestly, anybody who's touching that veteran, anybody who is in that position to help them, as well as the role of the veteran. Because again, oftentimes this is not something that we can do for them, but it's also not something that they can always do on their own, right? So it's about finding that balance, and we can support them where they need it. All right.
So, yeah, and I agree with that completely. And I like to also share with my veterans, like, the self-driven, the veteran-driven portion, really putting yourself in that driver's seat, taking ownership of the situation, not blaming yourself, not, judging yourself for it, but saying, hey, this is my thing. I'm going to work on it. I always say it's not your fault you were cut or that you were injured, but you owe it to yourself to, take care of that wound. To treat it so it will heal, so you don't bleed on yourself or someone else, and that's kind of how we talk about it. And, I think that's very important part of it. So what is a peer specialist? That is me. So a person with a mental health or co-occurring disorder, like mental health substance use, who has been trained to help others with these disorders, same situations or similar, identify and achieve specific life and recovery goals. So we're kind of like a supplement to their treatment plan with their, psychologist or psychiatrist or social therapist, social worker, whomever. So what we do is we kind of help, collaborate with the team, and we kind of help, help them identify and remember what their strengths are, that are just maybe kind of buried because of what they're going through. So we are actively engaged in the recovery models, which is what we were just looking at, the multifaceted area. And what we do is we kind of model recovery. And so when I meet with a veteran, I say, okay, you know what? I've been in your shoes. We have similar stories. And, I've been there. I know what it's like to feel like that. You're not alone. And guess what? We're not going to judge you. I'm certainly not judging you. This is no different than if someone had diabetes and needed insulin, and monitoring with their doctor. So we're going to get through this. And so we kind of model recovery. While everyone is unique, there are things we can share, like, this is what worked for me. You're unique, you're different. We have, maybe different values or goals or cultures, but here's some things that worked for me. Let's talk with your team. Maybe it's worth a try. And it kind of gives them like buy-in to their treatment as well, because especially with veterans especially, sometimes they have a difficult time like opening up and trusting someone who may not be a veteran. So it can be very beneficial. There have been many times where, a provider has come to me and said, hey, this veteran is having a little bit of hard time relating because he says, I don't know what it's like to be a veteran. Or, I don't know what it's like to have PTSD or depression or whatever. And so I'll come in and say, hey, maybe they do, maybe they don't share that experience. However, and try to kind of work together to kind of bridge that and say, hey, let's give it a try. They have expertise in this area. How can we kind of tap into that? And kind of gives them buy-in, and helps them kind of open up and trust. And then we just kind of like walk along with the veteran as they start their journey towards recovery. Thank you. So what do we do exactly? So when we first meet with a veteran, we often share our own recovery story, providing kind of hope and modeling as an example that, hey, you know what? I've been where you are, but guess what? I'm doing so much better now. And this is, I'm so glad I stuck around. I didn't want to at several points in my life, and I'm so glad I stayed around. And so it kind of can give them a little bit of hope. We also help cultivate the veteran's ability to make their own informed, independent, and healthy choices with an emphasis on their own role in treatment. I'm always reminding them, you were in the driver's seat, and you don't have to white knuckle it anymore. I did that for many, many years, just white knuckling it. I can do this, I guess, I don't know. And I just try to tell them, you don't have to do that anymore. Yes, you're still in the driver's seat, but we're here with you. And wherever you're wanting to go, we're gonna see how we can help you get there. So we kind of help them. I always like to help, identify what their interests are or once were, because a lot of them come to me, they're like, I haven't done anything in years. I used to like bowling, or I used to like hiking, but I just haven't done it because I've been so depressed. Or I really liked going to church, but I can't seem to find myself to do it. So I always try to kind of pay attention and dig into those and add, kind of help them find those again. Because like for me, it all got stuck in the muck. Like my strengths were there and my interests were there, but it was all covered up. So I try to help them remember who they really are as a person aside from their diagnosis. Like she had said earlier, a lot of people get stuck in that as being their identity. Well, I've got this diagnosis. I'm bipolar. I guess I'm never going to get better and I'm just bipolar. People tend to forget that, okay, so you have bipolar. That doesn't make you, the disease. It just means that it's something that you have to, learn to cope with. Okay, so what else do you like to do? What are your other goals? Let's figure out who you really are as a person. Let's remember who you are as a person aside from that. Even though it affects your life, let's find ways to make it affect your life less. So we kind of walk alongside the veteran. I always kind of talk with them about, you're on the path. Inside, you really know where you need to go. But sometimes you just need someone at the fork in the road going, hey, here's some light over here so you can see your way in the dark. Come with me. I've been down this path. I know where it goes. And so it's not something where we just drag them along. Just say, hey, come this way. Just kind of walk them along. We assist the veterans with community reintegration and finding connections and supports within the community through resources. So a lot of veterans and people in general with mental health challenges, they tend to isolate. Veterans, when they first get out, like we had spoken about before, it's a very critical time when they first transition. So they tend to isolate. They feel like they can't relate to non-veterans. They don't really do anything. So one of my favorite things is to call them up and say, hey, what are you doing to get out of the house? What are you doing to help on your self-care? Well, here's some resources. Hey, do you want to meet me at the park? Let's get you walking again. Whatever it is that they used to do or they want to do, I can kind of help get them to a point where they're empowered to do it again or find that again. We do group facilitation and individual peer mentoring as well as advocacy. So we help facilitate various groups that are recovery-oriented, art, music, just kind of like support in general, but they're always with goals in mind to help them get along with their recovery. We also advocate. Someone's having difficulty like navigating the VA system, which can be hard. We're right there to say, hey, what's the deal? Oh, okay, well, you're feeling intimidated by getting registered and coming to the hospital. No problem. Told the veteran the other day, I said, I'll meet you at the front door tomorrow. Let's go, I'll grab you a coffee, we can talk, meet each other, and then I'll walk you over and we can get the ball rolling. And that can kind of help with that intimidating factor and that feeling of overwhelm. We help with crisis support intervention under the supervision of a licensed provider. So I do that a lot on the suicide prevention team. Kind of check in with veterans, see how they're doing. If they're maybe experiencing suicidal ideation again, I get a licensed provider involved, a suicide prevention coordinator, and we get them taken care of. Community outreach to educate veterans on VA benefits and services. That's one big thing that's very important and close to my heart. When I got out of the military, I had no idea I was eligible for VA services. Of course, that was back in the early 2000s, and we didn't have anybody come talk to us. I always thought, oh, you had to be, an amputee, you had to be in a very serious situation to use VA services, and that's simply not true. So that's just another, area of what we do.
Thank you. Oh. So I will just say that the value of Crystal and the other peer support specialists cannot be underscored. It was, I think last week, I got tagged on an email that there is a veteran who is not doing well, not engaging in VA healthcare, and every time somebody contacts the person after getting out of the hospital, the response is, you don't understand, I don't want to talk to you, and that's the end of it. And peer support specialists are often in the best position of being able to catch that veteran's ear if we can figure out what is that challenge is acting as a barrier to keeping them from fully engaging or believing in their recovery. A peer can do that. They can talk to them from a veteran to veteran level. The moment they say, you don't understand what it's like, you're not boots on the ground. Oh, but I do. Let me tell you some of the things that I've been through. So it is wonderful. So I want 1,000 crystals. Either way, so this is generally speaking the process of VA healthcare, if we look at that continuum in a different format. So again, people typically enter through primary care mental health integration, not always. Those services tend to be short-termed, usually no more than 4 to 6 sessions, and they're typically very problem-focused, right? But there are some areas to where they do not pass go, they do not collect $100 or $200, been a while, that they do come straight to general mental health. So that's anything with regards to significant anxiety, significant depressive symptoms, any sort of what we call serious mental illness. So any diagnosis of bipolar, schizoaffective, schizophrenia, obsessive compulsive disorder, whatever it might be, they usually come straight to our BHIPs, which is our Behavioral Health Integrated Programs. So those are teams of therapists, psychiatrists, nurse, and peer support specialists that own a group of veterans to where they should know everyone on their healthcare team. So if they come in and they just initially say, I don't want to talk to someone, just give me a pill to make it better so I don't have these nightmares, they can see the psychiatrist and they can get their prazosin for a little bit. And when they're starting to feel like they might be ready to talk to someone about why those nightmares are occurring, the psychiatrist can give them a very warm handoff to tell them exactly who they could be working with and facilitate that introduction. So that to me is a very powerful thing, to have that wraparound care to where you feel like everyone on your team knows you and you can know who they are. So it's not kind of that punting from, well, I don't think my docs ever talk to each other. We want to avoid that. If there is something specific going on to where we do have a specialized treatment program, then we'll usually refer up to that if and when they are ready. Not every veteran wants to or needs to engage in a specialized program. Some of the treatments that are evidence-based for post-traumatic stress disorder are intense, right? Someone who is just diagnosed with PTSD and just started to kind of put those pieces together to understand that that's what they've been dealing with for the past 15 years. That's what they've been trying to white knuckle it through. Probably is not ready to have weekly sessions where they retell their story in exhausting detail and then listen to that audio tape every single night. So it can be a lot. But if and when they are ready for those specialty mental health clinics, we do have our PTSD specialty teams, both in the northern Colorado as well as the southern Colorado. Our substance use disorder clinic, where we do have intensive outpatient services for substance use. Family program, so marriage and family therapy. That is across eastern Colorado as well. It's stationed out of Denver. So if anyone is located in the south, it's usually by VVC or VA Video Connect. So that wonderful ability to kind of dial in and see your providers from home. The Life Skills Center, or the PRRC, Psychosocial Rehabilitation and Recovery Center. So a PRRC is a VA intensive outpatient program targeting individuals living with serious mental illness. So think bipolar, schizophrenia, schizoaffective disorder, major depressive with psychotic symptoms. And this is really focused on an education approach as well as a community reintegration approach. So this is not like the old day clinics of yesteryear. Instead, the goal of these is to give them the skills, the resources that they need in order to rebuild the life that they want, meet the goals that they choose, and how to reintegrate in their community. All right, so they do a lot of outings and a lot of kind of getting out of the VA. Intensive Community Mental Health Recovery Services, or ICMHR, ICMHR is how they're pronouncing it these days. That's also targeting our severe mental illness veterans, or veterans living with SMI, and that is when individuals have had I think the cutoff is 3 hospitalizations in 12 months. So if there is someone that we see is just needing additional support that the outpatient is not able to do, the ICMHR teams will meet with them at their home weekly. They will help them make sure that they're figuring out how to organize their medications, how to set standards, they're completing individual therapy and increasing sorts of community reintegration, with the goal of helping to prevent further hospitalization, prevent further deterioration, and get them prepared to fully engage in outpatient care as they move forward. Vocational rehabilitation services, wonderful kind of continuum of care. Anything from just kind of assistance with directing veterans to organizations and community places that are apt to hire veterans, all the way to transitional work or compensated work therapy, which is where they can actually work to get the veteran who hasn't been able to work in a very long time and does need additional supports, a position for a short period of time, typically 6 months, at or around minimum wage, tax-free, to start to rebuild their ability, their history of work, with the goal of getting them started, having them be able to work in an area to where they are supported to continue their mental health care, and then graduate on, start looking for continued work in the community. Neuropsychology, they'll do the testing, they'll figure out kind of what's going on, cognitive rehabilitation, so our veterans that are experiencing traumatic brain injury. Health psychology, I need another 45 minutes to kind of go down the list of everything health psychology looks at. Everything from people who are experiencing palliative care, dementia, to sleep health issues. You name it, health psychology probably has a hand in it. HUD-VASH, which is part of our healthcare for homeless veterans. So again, helping veterans that are at homelessness, trying to secure housing first, and then starting to figure out what are their barriers to maintaining that housing and connecting them with the services that they might need in order to start to build their future. And then, of course, psychiatric emergency services. So our ER, right? After that, we do have residential treatment. Valor Point is a residential treatment program for people with mental health disorders and substance use that are co-occurring. And it focuses primarily on housing needs as well as employment. We are in the process of rebuilding our residential program for PTSD, and that is expected to open in, I think the last time I heard it was May 2022. Mm-hmm. So we'll hope we're on target for that. And then acute psychiatric inpatient services. So if somebody does get to the point where they recognize and they are having thoughts of harming themselves, or they're not able to white knuckle it on their own, we want them to be able to come in and be in a safe environment where their needs and wishes can be respected, to where they can get a high level of care needed to help them find their feet on the ground again, and then figure out how to move forward. So that would be our acute psychiatric inpatient unit. All right, so remember how I said we need a lot of time for health psychology? That's why. This is what we call our organizational chart, and this is a much smaller version than the full one. So this just kind of looks at what some of our different healthcare systems are organized. So there are the mental health treatment programs that I just went through. They're all the different health psychology spelt out, as well as the support for justice. So veterans that are involved in the legal system, that is where the Veterans Justice Outreach Officers and so on can be done. So whole health is a new approach, and I will be brief because we are pretty much out of time here. If you can go to the next one, I think. Sure. Yes. So whole health is a different approach to VA healthcare that recognizes that the veteran is a whole individual. What a novel approach, right? So the idea with whole health is to put in that question of why is your health important to you? And then to start looking at what are the aspirations, the goals, the values that support that. And working with the veterans to start to look at those different elements that can support their whole health and wellness. Go to the next one. So Introduction to Whole Health is offered once a month. It is offered by one of our peer support specialists who is trained in this. And it is the second Tuesday of the month from 9 to 11. Like so many of our services right now, it is offered virtually through the VA Video Connect. All are welcome. Just some resources that we will leave up there, but I believe that is the last slide, and we are out of time.